Okay, so that's a very valuable lesson that we do go into early surgery now, but you should know when to refer for these cases. Now, the last talk of the day is role of anti-VEGF in diabetic retinopathy by Dr. Pappa, Associate Professor, RIO Trivandrum.
Okay. Thank you, KSOS, for giving us this platform. So mine will be a very basic presentation of anti-VEGF in diabetic retinopathy. So when will you inject? Again, the common indication is central involving macular edema, and the CSFT is more than 315 microns in males and 305 in females. That is the Heidelberg measurement. And how you are injecting, what is the frequency of injection? You can follow either two regimes, the PRN regime and the treat and extend regime. In PRN regime, actually we are giving monthly injection till the visual acuity and the OCT stabilizes. Then you follow up the patient monthly, and if you are seeing any signs of activity in OCT or the vision deteriorates, you can inject. But in treat and extend, what you do is after the 3 loading doses, you can extend the interval of injections by 2 to 4 weeks. If the visual acuity is stable and the OCT is also stable, then the injection intervals you can extend up to 3 months. And in between, if you are seeing any signs of worsening, you can decrease the intervals by 2 to 4 weeks and give monthly injections. Now, previously we used to do the grid laser. Now we have changed to the anti-VEGF. So why not laser? These are the different studies which shows that the long-standing visual outcome and also the macular edema, the better results are with the anti-VEGFs. Lasers, of course, you can give in pregnancy and in non-central involving macular edema if the visual acuity is less than 6/9, and you can actually combine anti-VEGFs with laser. Now, this one patient with 4 injections in 6 months, you can see the response. The cystone macular edema has come down. And this patient with 3 injections of biosimilars, vision improved from 636 to 69. This is the patient with 2 injections, 6/60 to 612. So it is not indicated in certain situations like ischemic macula. And as Thomas was telling, taut hyalod, ERMs, and there is vitreomacular tractions. And in some systemic conditions like diabetic nephropathy, even if you inject with SRF and cystoedema, the patient may not respond. So you have to control the systemic factors, then only inject. And if the patient has a recent MA or stroke that is within 2 months, it is better to withhold the anti-VEGF injections. Now, certain biomarkers in OCT, they shows poor response to anti-VEGF, like the drill or the ellipsoid zone or external empty membrane disruptions. Steroids, you can give if they, as Geeta was telling, failed anti-VEGF trials, you can wait for 6 months not responding, you can give steroids. Usually long-term steroids like DEXA implants are preferred. And in conditions like if anti-VEGF is contraindicated, but the chance of cataract and glaucoma should be explained. Then the choice of anti-VEGF. So as Sir was telling, if the patient has a mild visual impairment, all the 3 works, that is aflibercept, ranibizumab and bevacizumab gives good results, the same results, but the vision is moderate to severe, the aflibercept is superior to the other 2. So when will you change an anti-VEGF? If you are seeing less than 20% reduction in central retinal thickness, even after 3 to 6 injections, or less than 5 letters improvement, you can change the anti-VEGF. If you are using bevacizumab, you can change to ranibizumab and then to aflibercept. Now, what is the role in NPDR? So the different studies where anti-VEGF is given for central involving macular edema, it shows that it actually arrests the progression to PDR also. And there is a decrease in the diabetic retinopathy severity scale also. And this action is better in severe NPDR compared to mild NPDR. Now the PDR. So what is the role in PDR? So these are the different studies which shows that at 2 years follow-up, the visual acuity is better in injection patients, visual field is better, and the need of vitrectomy is also less. But at 5 years, the results are comparable except for the visual acuity part, which is better in the injection group. So all depends on, in a country like India, again the cost factor, patient complaints, and the associated risk of intravitreal injections like endophthalmitis should be explained. So in a case like this where you are seeing a high risk PDR without macular edema, Again, laser, PRP is the gold standard, and you can give anti-VEGF if there is macular edema development, and there is a hybrid approach you can choose. If it is a high-risk PDR with macular edema, anti-VEGF is the first line of treatment. And patients like this post-PRP with rebleed, you can do add lasers, but injection also works in these patients. In case of advanced diabetic eye disease, prior to vitrectomy, 1 week prior to vitrectomy, we can inject so that it reduces the intraoperative bleeding during vitrectomy. And a pre-retinal hemorrhage, so was showing, the treatment of choice is vitrectomy, but you can try one injection of anti-VEGF. In bilateral fresh VH, if there is no retinal detachment, again you can try one injection of anti-VEGF. Now the newer anti-VEGFs, the most commonly used ones are the brolucimab and the faricimab. Advantages are less number of injection, more disease control. Now biosimilars, what are they? They are comparable in quality with the original molecule. They are similar in pharmacokinetics, pharmacodynamics and efficacy. Advantages are very cheap and less time for production. And the complications are again the reactions because of the immunogenicity. These are some of the biosimilars for ranibizumab. Now, biobetters, what are they? They are actually better than the original molecule, but it's an investigational new drug, and the cost is also very high. So that's all. Thank you for the patient hearing.
So thank you. With that, we come to the end of this session. Any questions? We can just take one question if any need. Okay.